Hello, welcome everyone to this webinar on new advances in the prevention and management of food allergy. The timing of food allergen introduction has been researched extensively in the context of allergy prevention and has informed change in guidelines. There is also interest in the effect of diet diversity. This calls for strategies that fits within the holistic approach for the introduction of solid foods. Human milk oligosaccharides, or HMO, are the third largest component in breast milk. They resemble mucosal glycans at the host microbe interface, supporting HMO to play important roles in orchestrating the host microbial interactions via multiple mechanisms. These include preventing pathogen growth and adhesion, reducing inflammatory responses, and aiding the mucosal barrier function, as well as promoting an early life healthy microbiome. Observational studies with breastfed infants suggest that HMOs support the immune system with protection from infections and possibly allergies. It has been shown that feeding a formula with HMO reduces the risk for infections in both healthy and infants with cow's milk allergy. So that were my welcomes word. I'm Professor Vandenplas, the chairperson of this webinar. Next important message for you is that the talks in this live stream session have been pre-recorded. All speakers are available online and will address the questions coming in through the chat. But the first speaker of this webinar is Dr. Carina Venter, and she will tell you on how to implement nutritional strategies for food allergy prevention. So preventing food allergy, what's important about it? The timing of food allergen introduction has been researched extensively in the context of allergy prevention and has informed changes in guidelines. There is also interest in the effect of diet diversity. This calls for strategies that fit within the holistic approach for the introduction of solid foods. So what are the learning objectives of the presentation of Dr. Venter? Well, there are three major objectives. First one, to provide an overview of current guidelines and their evolution for food allergy prevention. Discuss how early food allergen introduction and food diversity can be beneficial for the prevention of future food allergies. And last but not least, provide guidance on practical information regarding food allergen introduction, timing, dose, frequency, format. So let's listen to Dr. Venter.
Hello, my name is Carina Venter. I'm an allergy specialist dietitian in Denver, Colorado. We will be discussing how to implement nutritional strategies for food allergy prevention. Please take a note of my disclosures. The objectives of my presentation today is to provide an overview of current guidelines and their evolution for food allergy prevention, to discuss how early food allergen introduction and food diversity can be beneficial for the prevention of future food allergies, and finally to provide guidance on practical information regarding food allergen introduction in terms of timing, dose, frequency, and format. We have seen quite a change in food allergy prevention guidelines over the last decade. For your reference, I've summarized the guidelines and I've also indicated the changes using different colors. The next slide, however, summarizes the changes in a much easier format to follow. We started in 1998 and about 2000 advising high-risk families to avoid or suggest that they may wish to avoid peanut and or other food allergens during pregnancy, breastfeeding, and the infant's first few years of life. And high risk, as I've already mentioned, refer to a familial risk of allergic diseases. The guidance was then changed to there may be no need for avoidance, but still no guidance on active introduction was given. We've seen a change in the guidance in the last 2 to 3 years since the publication of the Leap and Eat study and a number of other studies to suggest or recommend no need for food allergen avoidance during pregnancy, breastfeeding, and no need to delay or active introduction of food allergens, particularly peanut and egg, in the infant's first year of life. The guidance relate to either the normal or general population or high-risk infants, depending on the country in question. We've also seen a change in definition of high risk. High risk now refers to the infant's own risk of developing food allergy, and high-risk infants include infants with eczema and or an egg allergy. To summarize the guidelines in a very practical format, advice would be to introduce food allergens when infant is developmentally ready to eat and once a few foods have been introduced. A practical approach in dealing with high risk is that really until we can clearly define high risk, perhaps it would be sensible to treat all infants the same. We know that about 25% of children with peanut allergy never had eczema or an egg allergy. Another practical approach is that we have better data for peanut and egg introduction, which I will discuss during the course of the presentation, but we still need more data for all the other major allergens. Looking at the practical approach that we've developed in the allergy world, it is nice to get some validation from other publications coming from the USDA and EFSA. Both the USDA review paper and the EFSA guidance recommend introduction of solid foods once the infant is developmentally ready, and EFSA go as low as 3 to 4 months age of introduction of pureed food, providing the infant is developmentally ready to eat. Both the USDA and EFSA recommend or suggest introduction of peanut and egg in early infancy for the prevention of peanut or egg allergy. The USDA further mentioned that we need more data on diet diversity for the prevention of allergy outcomes. I will discuss the use of diet diversity or the association between diet diversity and food allergy development later on in the presentation. And the USDA also conclude by saying that we need more studies, and studies particularly focusing on controlling for confounders. In terms of introducing peanut as it is, or lumps of peanut butter, is considered to be a choking risk for infants. There is therefore guidance published by NIAID at the bottom of the slide. You can see the link of infant-friendly or infant-safe forms of introducing peanut. You could use peanut flour or thin peanut butter, or even peanut puffs that could be crushed out or mixed with water or formula. The dose for peanut allergy prevention is about 1 to 2 teaspoons a day, served 1 to 3 times a week. And it really relates to 1 heaped teaspoons or 2 leveled teaspoons of peanut butter or peanut powder. It's a little bit more complicated to practically implement egg intake for prevention of egg allergy. The egg should be well cooked according to the EAT study and the PETITE study. Well-cooked forms of egg is highly debated, but it does include boiled egg. It could be scrambled egg if it's really been heat treated for quite some time. Some people also suggest that French toast could be considered well-cooked egg, but it's important to make sure that the egg is cooked right through the bread. The dose recommended for prevention is also still debated. Some studies use as low as 1/100th of an egg, whereas about 1/3 of an egg was used in the EAT study. So a dose for prevention that would make practical sense and also fit healthy eating guidance would be 1 to 2 tablespoons of well-cooked or hard-boiled egg once to twice a week. Very little data or almost no data is available for early introduction of the other allergens for allergy prevention, and we can therefore take guidance on intake of these allergens from healthy eating guidelines. For wheat, we normally recommend iron-fortified cereals, about 1/4 to 1/2 cup of cereal or pasta, or 1 to 2 crackers daily. Sesame could be given as tahini paste in a serving of 1 to 2 teaspoons, but healthy eating guidance give no indication on how often infants should be consuming sesame. Milk could be given as full-fat yogurt or plain yogurt. Fruit and vegetables can be mixed in with plain yogurt. In most countries, it would probably be mixed fruit that's mixed in with the yogurt. And 1 serving, which is about a small pot of yogurt, or perhaps 1/4 to 1/2 cup of yogurt or milk, could be given daily, even up to twice daily. In terms of fish, the recommended dose is about 1 to 2 tablespoons, but the amount or the weekly consumption of fish would vary according to local country guidance, and the guidance normally varies because of concerns about mercury content of the fish. In terms of shellfish, a serving is considered 1 to 2 tablespoons. Again, weekly intake varies between countries. Tree nuts, again, is highly debated whether we should eat 1 kind of tree nut on a daily basis, or whether we can mix the tree nuts as 1 to 2 teaspoons of per serving once to twice a week. So the guidance on that also need to be clarified, because there's no clear guidance from either healthy eating guidelines or allergy prevention guidelines. In order for infants to consume soy, soft tofu is recommended. Soy yogurts could be used as well, and a serving is considered 1 to 2 tablespoons. But again, we have no guidance on how often soy should be consumed on a weekly basis. If mothers opt or parents opt to choose a tree nut butter once to twice a week, opposed to giving a small bit of a particular tree nut on a daily basis, I would like to reference you to this table that we, with a recipe that we have prepared and have submitted for publication. Then moving on from the food allergens. Diet diversity have been studied to look at allergy outcomes, and diet diversity can be defined as the number of different foods or food groups or even food allergens consumed over a given reference period. Diet quality has no official definition. It is supposed to measure the nutrient adequacy of the diet, but it's not always the case. But in terms of allergy outcomes, the indices that have been used in pregnancy include, for example, the Mediterranean Diet Index, but I won't be discussing these today as there's no data on the use of diet indices in infancy and allergy outcomes in later childhood. So in terms of diet diversity, the European Academy of Allergy, Asthma and Clinical Immunology brought a task force together led by myself and Professor Liam O'Mahony to define what does diet diversity mean in relation to allergy outcomes. We performed a systematic search of the literature, and we were able to find at the time only 1 study looking at diet diversity in infancy versus allergy outcomes in later childhood. And this was the paper by Caroline Rudet, where they found as diet diversity in infancy increased, so does the likelihood of developing food allergy in later childhood came down. Shortly after the publication of the EAACI paper, I published my own data from the Isle of Wight using 4 different measures of diet diversity, and I looked at the association with the development of food allergy over the first 10 years of life. For the purpose of today's presentation, I will focus on the number of foods introduced, number 2, in the first 9 months of life, and the number of food allergens introduced in the first 12 months of life. which is number 3 on the slide. In our study, we found that the probability of food allergies over the first 10 years of life significantly came down as the number of foods introduced in the first 6 months of life increased. In fact, for every additional food given by 6 months of age, the odds of developing food allergy over the first 10 years of life was reduced by 11%. We also looked at the probability of food allergies over the first 10 years of life compared to the number of allergenic foods introduced over the first 12 months. And what we see was that for each additional food allergen introduced over the first 12 months of life, the likelihood or the odds of developing food allergy by 10 years of age was reduced by 33%. So then when we look at possible mechanisms of how diet diversity may affect infant or childhood allergy outcomes, one of the most plausible mechanisms involved is the infant microbiome. There are no published data looking at infant diet diversity versus the infant microbial diversity. But I am actually sharing this study from Wegrzyn et al. With you, where they looked at family food intake in the first year of life versus microbial gut diversity measured by the Shannon index. So if we assume that increase in family food intake is a reflection of increase in diet diversity, then you can see here in figure E on the slide that increased of diet diversity or family food intake is significantly correlated with an increase in microbial diversity. The same applies to protein, which is figure A on the slide. As protein intake increases over the first year of life, so does microbial diversity. And the same is true for fiber. Very interestingly, and as we expect from adult studies, as fat intake increases over the first year of life, we see a reduction in microbial diversity in the gut. And that is perhaps just something to be mindful of when we introduce food allergens, because many of the food allergens, particularly the nuts, are sources of fat. Then the last slide that I would like to share with you is perhaps also not a direct reflection of diet diversity, but still very interesting data to look at. As infant intake of yogurt, fish, fruit, and vegetables increase over life, so did we see an increase in butyrate production. Or perhaps it's better to say that infants with higher consumption of yogurt, fish, fruit, and vegetable had higher butyrate levels, a short-chain fatty acid, in their fecal samples that were analyzed. We also know that as butyrate production increase, so does T regulatory cells get upregulated, and we see reduced food allergy outcomes because T regulatory cell is associated with increased levels of the cytokine IL-10 or TGF-beta. So, and we have also showed you in the slide on diet diversity that the study by Rodet et al. Previously published increased diet diversity in the first year of life was associated with reduced food allergy outcomes up to 6 years of age, which really makes the microbiome a very plausible mechanism for tolerance induction in infants. So really, just to summarize, the guidelines keep changing. We change our definitions of what is high risk, we change our definition to who the guidelines apply to, and we change our definition about whether allergens should be avoided, not avoided, or actively introduced. But at the moment, all the guidelines agree. Let the babies eat. Let's get them onto food when they are developmentally ready, and let's not delay the introduction of food allergens, irrespective of their risk of developing food allergies. There are practical dilemmas for food allergen introduction. We have to look at RCT outcomes for dose, duration, and frequency and format of food. But really, at this point in time, we only have clear data about peanut introduction, dose duration and the format that we should be given, and how often the peanut should be eaten. The data is less clear for egg, but I think it is safe to say that at this point in time, we want to give infants a well-cooked egg in a format that infants would eat, probably about once to twice a week based on healthy eating guidelines and some guidance from allergy prevention trials. In terms of the other major allergens, we have either very limited data or no data about dose and frequency of duration. And at this point in time, we have to rely on healthy eating guidance where it relates to a particular food allergen. But where the data is completely lacking, I think it would be safe to say, let's not delay the introduction of the allergen and make it part of normal dietary intake according to family practices. Diet diversity in infancy and allergy outcomes, yes, the data is slightly unclear when we look at all allergy outcomes, but when we focus on food allergy only, I think it would be fair to say that we have two studies both showing significant reduction in food allergy outcomes with increased diet diversity in the first year of life, despite the fact that these two studies use different definitions. And then finally, looking at mechanisms, as I've already mentioned, if we consider increased food intake in the first year of life as a measure of diet diversity, then we have one study indicating that as food intake increase, so does microbial diversity in the infant gut increase, and another study showing that infants with higher intakes of fish, fruit, vegetables, and yogurt, to some extent reflecting diet diversity, was associated with increased levels of butyrate and T-regulatory cell function, and therefore less food allergy outcomes. So I hope you found this informative, and I look forward to further discussions during the question and answer sessions. Thank you for your time.
Now that we have heard Dr. Venter, we will move to the next topic, which are discussion about the benefits of human milk oligosaccharides in the management of cow's milk protein allergy. Human milk oligosaccharides are the third largest component in breast milk. They resemble mucosal glycans at the host microbe interface, supporting HMO to play important roles in orchestrating the host microbial interactions via multiple mechanisms. These include preventing pathogen growth and adhesion, reducing inflammatory responses, and aiding the mucosal barrier function, as well as promoting an early life microbiome. Observational studies with breastfed infants suggest that HMOs support the immune system with protection from infections and possibly allergies. It has been shown that feeding a formula with HMO reduces the risk for infections in both healthy and infants with cow's milk allergy. So the first presentation in the second part will be provided by Dr. Norbert Sprenger on human milk oligosaccharides for the immune system development. The learning objectives of this presentation are to introduce HMO and their unique structures and benefits, to discuss the mechanisms through which HMO supports the infant's immune system, and finally discuss the data on the benefits of formula supplemented with the two HMOs, 2FL and LNNT, in healthy infants. Now that we've heard Dr. Sprenger, we will listen to Professor Anna Nowak Wegrzyn on new data on the benefits of HMO in the management of cow's milk protein allergy. Professor Wegrzyn will teach us on how to describe the new evidence supporting the addition of human milk oligosaccharides as an important component for the management of cow's milk protein allergy. I hope we will learn a lot from this presentation of really new data.
Hello, welcome everybody to this session, and I'm very pleased to be here and talk to you about human milk oligosaccharides for immune system development. Here are my disclosures. I'm an employee of the Société des Produits Nestlé in Lausanne, Switzerland at the Nestlé Institute of Health Sciences. What will I talk about? I will talk about what are HMOs and what is so special about them. I will then focus on the role of HMOs supporting the infant's immune system, and focus in the third part of the presentation on learnings we had from the benefits of formula supplemented with the two HMOs, 2FL and LNNT in healthy term-born infants. If we look at the gross composition of breast milk, you can see that water is the main component, followed by the solids, micronutrients, and HMOs. So the macronutrients are divided into the lactose, this is the major component, followed by lipids, and as a third most abundant component are the HMOs, with amounts of 5 to 15 grams per liter reported, followed by the proteins. Now, if we look at the division of the HMOs, we can divide them into three main classes. The first one are the core structures, kept in blue. Second are the fucosylated HMOs, kept in red, which are a major component in human milk. And the third one is the sialylated HMOs with a sialic acid in terminal positions. Now, how do these HMOs look like chemically? So they're all elongations of the milk sugar lactose by either galactose and N-acetylglucosamine, which gives the core structures like LNNT and LNT, which are shown on the right side on top. And then these can be further decorated, or lactose can be further decorated with fucose. These are the middle molecules that you see there with the red triangle, or with a sialic acid, which is the lower group with the purple diamond. There can be also mixtures of the fucosylation and sialylation, and there can be much longer molecules that contain many more of the N-acetylglucosamine galactose disaccharides. Now, why are these so special? If you look at the mucosal surface, you can see those are actually fully covered by glycan structures. That's illustrated on that confocal micrograph, where we colored the glycans with lectins in different colors, in green and red. And you can see in the box the major structures making up these glycans. And when you compare these to typical HMOs, you can easily see that they are very, very similar, if not identical in many cases, to the structures provided by HMOs. So there's something very particular in the structures provided with HMOs on this mucosal surface that resemble these. And this may indicate that in fact there is an interaction happening that is very particular, that cannot be mimicked by other classical prebiotics. So how would classical prebiotics look like in comparison to HMOs? You can see here the so-called GOS or galacto-oligosaccharide structures. They are all elongations also of lactose, but only with the monosaccharide galactose in different linkages. There are some examples shown here as trisaccharides with 3GL, 6GL, 4GL. And then you have the so-called FOS or fructo-oligosaccharides, inulins. So these are chemically and structurally very, very different because they're all built on the table sugar sucrose and elongated with a fructose, which is not the same as fucose. This is typically what an infant would get during the solid food introduction from plants, because FOS are typical plant carbohydrates and storage carbohydrates and fibers. Now, if we look at the expected HMO functions based on literature and findings from basic research, we have here kind of a summary view on that. So there's different pathways how the HMO can act and were shown to act. One major pathway is the middle one, going through the microbiota, and this mainly through the bifidobacteria in the microbiota in early life, where this can lead to a deflection of pathogens by competitive competition and exclusion of pathogens. And then, of course, the microbes can have different metabolites that can have, again, direct interactions with either the epithelial cells or immune cells. There's a lot shown on, for example, short-chain fatty acids like acetate. Then you have HMOs that may also directly act on the epithelial surface, probably through glycan-binding proteins that would otherwise interact with surface glycans. And then there is some that go actually systemic. It's about 1%, that are also in some cases reported to directly interact with CYNR1, for example, as an immune receptor, or other galectins that could have a role in modulating immune cells. Now, a classical view is also the HMO interaction directly to deflect pathogens, because pathogens usually attach to the glycans on the mucus and the cell surface on the epithelia. And since these HMOs have very similar structures, that was a very early concept that they would build soluble ligands for the lectins of pathogens and basically deflect them from finding their real target. So all that together, that leads to a strengthening of the gut barrier function, probably helping the education of the immune system. And if we go beyond this, we will not cover today, there's also reports how they can modulate the nervous system function and even beyond the gut into the brain. So we will focus here on the support of immune system function. Now, what do we know about the HMOs in relation to the microbiota, and here mainly the bifidobacteria? There is several association studies associating specific fucosylated HMOs with a bifidobacteria-dominated early life microbiota in breastfed infants. Then there is several and quite detailed investigations looking at different bifidobacteria. Even within the same species, you can have different strains that can or cannot use certain HMOs, and the molecular machinery that allows them to do so. Some eat the HMOs from outside, in a kind of an liberation of hydrolases outside, so they can nibble off the end products like fucose, sialic acid, and so on. And this could either lead to cross-feeding to other microbes, or they can internalize then these as a growth substrate. Others, and this is maybe a more interesting group of bifidobacteria, internalize the whole of the HMO and then basically use them as a substrate only for themselves and do not lead to much cross-feeding to others. Now, there is another interesting observation, and this is actually illustrated here on the right side with the graphs. That is that the HMOs not only boost the growth of the bifidobacteria and of certain bifidobacteria, like in this case Bifidobacterium longum infantis, but they specifically boost the metabolic activity shown in acetate formation here as short-chain fatty acid formation, and this superior to, for example, FOS, that also shows the growth on the top panel, but in terms of metabolic activity, this seems to be inferior to the boosting by an HMO like 2'-fucosyl lactose. Now here I will show you one example of a very nice study that showed that the presence of strains of bifidobacteria, in this case it was specific Bifidobacterium brevis strains, that can use HMOs like 2'-fucosyl lactose, leads to a microbiota that is very much dominated by bifidobacteria. That's on the lower left side panel with the Bifidobacteriaceae in the red group. So this is a community type that is very much dominated by bifidobacteria. As you can see, it's above 80%. And that is because these infants have bifidobacteria that can use the HMO. You see at the same time the 2FL decreases in the stool, and most interestingly, again, you can see the boosted acetate formation, again leading to lower pH as an indicator and this higher acetate formation. So this is very interesting because here we enter now into the area where we have the crosstalk then to the epithelia and to other cells that can maybe benefit from this new ecology that is dominated by certain metabolites. Now, what do we know from preclinical basic research data? So here the HMOs were shown to have different ways how they could work and how they could actually modulate the pathogens. So in the first example, there's an inhibition of growth. This is relatively recent research where the researchers showed that specifically LNNT interacts with glycosyltransferases of the bacteria of this group B Streptococcus to block cell wall formation and thereby blocks the growth of this bacteria. So this is a kind of an other mechanism that was not discussed previously in the literature. Then there's the more classical view that I mentioned with the prevention of adhesion. A good example for this is Campylobacter jejuni that was shown to be inhibited by 2'-fucosyl lactose again. And then there is another mechanism that leads more to a dampening of inflammation, and as a consequence, you would have a dampening or inhibition or reduction of the pathogen load, for example, with pathogenic E. coli. And at the same time, a strengthening of the gut barrier function. So this part is shown for different molecules, but also again for 2'-fucosyl lactose. Then for Streptococcus pneumoniae, if we come more into the respiratory tract, again, very nice studies showed inhibition of adhesion by, for example, LNNT in this case. Now for respiratory syncytial virus, influenza virus, again, different mechanisms were proposed. Some, I think, are more likely to happen through a modulation of the mucosa and the epithelial barrier. Modulating the response and thereby the pathogen load, for example. And I will show you one example later on a vaccine response for influenza. Now, in terms of clinical observations in breastfed infants, there is a whole series of studies today that looked at 2'-fucosyl HMOs in breast milk and breastfed infants in terms of risk for diarrhea and respiratory infections, and they all reported a lower morbidity, diarrhea, and respiratory infection risk when the infant gets higher 2'-fucosyl HMOs. Now, we did a study in Dhaka, Bangladesh, where we looked at an infant and mother cohort. We could not have access to breast milk samples, but we could actually genotype the mother and use the fucosyltransferase 2 and 3 genotypes as a reliable surrogate for specific fucosylated HMOs, and then try to see if we can find correlations to later health outcomes in these infants. What did we find? So we found that the FUT2 positive breast milk, so the one that contains 2'-fucosyl lactose, is associated here with a low risk for infants to have acute respiratory infections during the exclusive breastfeeding periods from 0 to 6 months, indicated with the arrow, but not beyond that. And we see that actually FUT3 or in the breast milk had no impact, and also the infant genotype had no impact here on the risk for respiratory infections. Now, if we go a bit more into the mechanism, I think we always need to consider that the HMOs work in a multifunctional manner that is nicely illustrated on the left side, with the HMOs acting through different ways. And here are two examples how maybe they act in terms of immune modulation. On the top right side, you can see immune response to a vaccine model, an influenza vaccine model, and you see there's a kind of a dose response in the response to the vaccine treatment when you have different amounts of 2FL in the diet, 2'-fucosyl lactose. In the lower panel, you can see for an allergic diarrhea model, also 2'-fucosyl lactose was shown to alleviate the symptoms together with 6SL, another HMO. Now, what did we learn from clinical observations in terms of allergy risks? So here we had a placebo control group of the FLORA study from Helsinki, and we looked at the FUT2 positive or FUT2 negative milk samples, and then basically tried to associate infant First, on the stool microbiota at 3 months, and second, on allergy risks up to 5 years of age. Now, what did we find? In terms of the microbiota, we see that the fucosyl transferase 2 positive HMOs alleviate the dysbiosis that is seen on the left side with C-section born infants, that's in the red, compared to the vaginal born infants in blue. And you see with the orange, when they get milk that is positive for the 2' fucosyl HMOs, the infant's microbiome moves closer to the vaginal born. And the group that is mainly affected are the bifidobacteria. And you can see that in terms of the family on the left side and in terms of some individual strains like Bif breve and other bifidobacteria that increase when we give the when the infants get breast milk with 2' fucosyl HMOs. Now, in terms of allergy, we saw a trend for a reduced incidence rate for IgE-mediated allergic diseases and eczema when the C-section born infants get milk that has no 2' fucosyl HMOs, indicating that something with these 2' fucosyl HMOs may actually delay the onset, as you can see on the top level, on the top right side of the graphs, where you see at 2 years of age, the C-section born infants that get the FUT2 negative milk have already a higher incidence of allergies compared to the vaginal born infants. And you can see on the 2FL amounts that are given in the early breast milk, there is a clear difference that is statistically significant. So something only happens here in the C-section born infants. Now let's see what we learned from formula-fed infants. So here's an example of a trial that tested galacto-oligosaccharides in the control formula-fed infants compared to galacto-oligosaccharides plus 2FL at 2 different doses in formula-fed infants. And as a reference group, breastfed infants were compared with the BF denominator. And you see there what these secondary outcomes of the safety trial showed is that the cytokine levels in the plasma of a subgroup of infants was approaching that one seen in breastfed infants and was different compared to the control infants that got only the GOS as a prebiotic. And this at baseline and also in PBMCs that were stimulated with respiratory syncytial virus, indicating that possibly this 2FL somehow modulates the immune response of infants. Now, what did we learn from our clinical trial with formula-fed infants and 2FL LNNT? So first, we learned that these 2 HMOs were well tolerated and supported age-appropriate growth. And second, we had some interesting observations on our a priori defined infection-related morbidities, especially on the lower respiratory tract, where we saw a lower risk for lower respiratory tract infections when they get the 2 HMOs in the formula, up to 1 year actually. And here I show these results for bronchitis in a relative risk ratio of 0.4, and the number needed to treat was about 6. And also what we see is that they had up to 1 year less need for antibiotics, again with a risk ratio of 0.7 and the number needed to treat of 6. So some very interesting findings in terms of infection risk that it was reduced with the 2 HMOs. Now, our main question was, can we find actually microbiota changes as a mode of action that could explain what we observed here in terms of the antibiotic use and lower respiratory tract infections? Now, what did we see in terms of antibiotic use? Here, I show you on the left side the community types that we see at 3 months of age. So you can see in the breastfed, we have mainly a red type of a microbiota community. In the control formula fed infants, we have mainly a green type. And when we give our 2 HMOs, we have about half of the infants that responded and became red, like the breastfed infants, and some were non-responders and they remained with the same community type like the control formula-fed infants. And when we now look at the formula-fed infants and try to correlate the community types to the incidence of or the need for antibiotic use. In this graph, I show you the time to first antibiotic use. You can see those infants that are formula fed and have a community type that is red, so very dominated actually with bifidobacteria, they have about a 2 times lower hazard ratio compared to the infants who have the community type that is typical for control formula fed infants, showing a nice association here of microbiota with the clinical outcome measure that we had. Now, we did not see any association in that case for lower respiratory tract infections. And so we went back to the data and looked a bit more into details. And what we see is that the lower respiratory tract benefit that we saw was mainly driven by the C-section born infants. That's shown on the forest plot here on the left side, where you see in the C-section born infants, we see the significant difference. We see it also for all infants, but we don't see it in the vaginal born. So the main driver for the effect that we have seen was actually the C-section born infants. So the trial was stratified for C-section, and we had about 36% C-section born in both formula fed groups. Now also in terms of microbiota, we see the biggest change, in fact, on the right side, on bifidobacterium increase in the C-section born infants. So when you have a dysbiotic situation, these infants seem to profit most from the HMO addition in the formula. Now we tried to investigate this further to see what could be mechanisms behind, and we just now made case control out of our formula fed infants, and we compare these two in terms of the bifidobacteria and of the main metabolite from bifidobacteria, which is acetate. And what you can see is nicely that acetate is higher in the controls that did not have an LRTI or a bronchitis up to 1 year, together with some specific bifidobacteria like Bifidobacterium longum group, and especially the infantis in the longum group. Now we back this up with some preclinical studies where we looked at the Bifinfantis stimulated metabolites, and we see that we have anti-inflammatory properties, either if we challenge an epithelial cells with TNF-alpha or with Salmonella. We also see less invasion with Salmonella, and this we see specifically with 2FL and LNNT, but not really with 6SL, another important HMO. And what we found is that 2FL and LNNT increase specifically more acetate formation of the bifidobacteria, and in fact the acetate can explain the effect that's shown on the right side for the Salmonella invasion, but also when we do a challenge with respiratory virus on a respiratory infection model, we can see that acetate, but also propionate would have a benefit here for the RSV infectivity, or in this case, stimulation of IL-8. So if we come to a conclusion, HMOs are different from classical prebiotics and resemble the glycans decorating our mucosa. So I think this is important to keep in mind, because this indicates there is probably very specific functions that we cannot simply mimic with other classical prebiotics. Then clinical observation studies with breastfed infants, backed by basic research, suggests that specific HMOs support the immune system, seen in protection from infections and possibly also allergies. A randomized controlled clinical trial with formula-fed infants suggests the HMO 2FL and LNNT specifically help to protect from lower respiratory tract infections and antibiotic use, in part, I think, through that effect they have on the early life microbiome development. And with this, I thank you very much for the attention, and I would like to thank our different collaborators internally and externally. Thank you very much.
My name is Anna Nowak-Wegrzyn. I am a pediatric allergist and the professor of pediatrics at the New York University School of Medicine in New York. And it is my great pleasure to discuss the new data on the benefits of human milk oligosaccharides in the management of cow's milk protein allergy. As a disclosure, I do receive an honorarium for this presentation from the Nestle Health Science and I was a recipient of the research grant and served as a principal investigator for the clinical trial that evaluated the hypoallergenicity of the whey-based extensively hydrolyzed formula with human milk oligosaccharides. The objective for this discussion is to describe the new evidence supporting the addition of human milk oligosaccharides as an important component of the hypoallergenic whey-based extensively hydrolyzed formula for the management of cow's milk protein allergy. We all know that breast milk is the gold standard of human infant nutrition, and it is an incredibly active immunologic fluid. It does contain many immunomodulatory ingredients, and it has the capacity to influence immune-related outcomes in infancy and early childhood. Human milk contains hundreds of proteins, such as cytokines, inflammatory mediators, signaling molecules, soluble receptors, as well as polyunsaturated fatty acids, human milk oligosaccharides, as well as a complex microbiome, because human milk is not sterile. To date, there's over 200 different human milk oligosaccharides detected in human milk to date, consisting from long as well as short chain structures in about 9:1 ratio. And human milk oligosaccharides are essentially probiotics. They are non-digestible oligosaccharides that are acting to stimulate the bacterial flora in the gut of an infant. And they represent the third most prevalent component of the solid fraction in human milk. In the context of cow's milk protein allergy, it has been shown that the profile of human milk oligosaccharides in breast milk may influence development, or may be a risk factor for development of cow's milk protein allergy, because in a large cohort of Finnish infants, mothers of infants with cow's milk protein allergy were found to have different composition of human milk oligosaccharides compared to mothers of non-allergic infants. With the advances in the synthesis of human milk oligosaccharides, the new generation of infant formulas are enriched with two specific human milk oligosaccharides that can be synthesized. This is 2-fucosyl lactose, for short 2FL, and lacto-N neotetrarose, L, N, and T. These two human oligosaccharides have been added to the whey-based extensively hydrolyzed formula. So first, I want to share with you the results of a study in which we've evaluated the hypoallergenicity of the new formula in a multi-center randomized clinical trial that was conducted in 11 clinical sites in the United States in 2017-2018. The results have been published last year. In that study, we've included infants and children between ages 2 months and 4 years that were essentially healthy, born at term. And those infants had a history of Ig-mediated cow's milk protein allergy. So they either had history of convincing allergic symptoms following ingestion of cow's milk or dairy product in the setting of a detectable cow's milk specific IgE or positive skin test, or they had high levels of milk specific serum IgE over 15 kilunits antibody per liter, or a large skin prick test more than 10 millimeters wheal, which those values have been identified in prior studies as highly predictive of clinical reactivity. In that study, we tested the new modified Althera formula that was enriched with 2 human milk oligosaccharides and was slightly different from the commercially available standard formula in that it had a lower content of whey protein, 2.2 grams per 100 calories. Control formula was the commercially available Althera with the whey protein content of 2.5 gram per 100 kilocalories. This control formula did not contain human milk oligosaccharides. Otherwise, the formulas were identical. The design is presented in this diagram. There were 67 subjects that were enrolled and randomized to receive either test or control formula during the first session of a blinded food challenge. Within 7 days, they underwent a second session where they were fed in a blinded manner with another formula. Along the way, there were some withdrawals from the study because of the inconclusive challenges or mistakes or errors in assigning the same formula for, during 2 challenges. So in the end, the intention to treat population was 67 in patients. Modified intention to treat was 64, and per protocol population was 61 participants. The results of that study documented hypoallergenicity of this new whey-based extensively hydrolyzed formula containing 2 human milk oligosaccharides because more than 90% of subjects participating in this study tolerated the new whey-based formula, and thus meeting the American Academy of Pediatrics criteria for hypoallergenicity of infant formula. I want to now focus on the very important aspect of breast milk, and it has been observed previously that infants exclusively breastfed for at least 4 to 6 months have a lower incidence of upper respiratory tract infections, lower respiratory tract infections, as well as gastrointestinal infections compared to fully formula-fed infants. And this protective effect is attributed to the immunomodulatory effects of the microbiome in the breast milk, as well as the effects of the human milk oligosaccharides. The beneficial effects of human milk oligosaccharides on respiratory and gastrointestinal infections include the reduction of the viral load in case of respiratory syncytial virus infection, as well as increased production of short-chain fatty acids by resident bifidobacteria, which results in the improved gut barrier function, and it has other broader anti-inflammatory effects. Human milk oligosaccharides also act as decoys for bacterial pathogens and interfere with their adhesion to the mucosa, as well as invasions. When the studies were conducted in infants with healthy infants fed with the formula that was based on cow's milk, intact cow's milk protein, those infants were observed to have significantly fewer lower and upper respiratory infections, as well as decreased frequency of antibiotics and antipyretics in the first year of life. So I want to discuss that study because it was a very interesting prospective randomized controlled multi-center interventional clinical trial of 2 parallel formula-fed groups conducted in Italy and Belgium. It is important to note that the study population included healthy full-term infants who were not breastfed, who were very young, younger than 14 days at enrollment, and they were assigned to either feeding with control formula or with the test formula containing 2 human milk oligosaccharides. There was also an exclusively breastfed group in that study for comparison. And the primary endpoint for this study was growth as per the non-inferiority design. And the study met its primary endpoint because it showed that considering all of the growth parameters, so weight, length, height, and circumference, there was no difference. And you can see that in this graph on the right, which shows the weight over time in the study in males and females, and the treatment with the formula with human oligosaccharides is shown in the red color, and the control formula is shown in the blue color. So the study showed conclusively that cow's milk-based infant formula that contains two human milk oligosaccharides is well tolerated, and that it supports normal growth in healthy infants. So the study met as the primary endpoint. But what was even more interesting in that study was that infants were fed the formula with human milk oligosaccharides had significantly fewer reported infections, such as bronchitis and lower respiratory tract infections, as well as antibiotic and antipyretics use. So you can see in this forest diagram that there are the odds ratio of having reported infections, whether it's bronchitis or lower respiratory tract infection or antibiotics or antipyretics, were moved towards the lower odds and suggesting protective effect of this formula. Therefore, the next step was to evaluate hypoallergenic formula in infants with cow's milk protein allergy. Infants with cow's milk protein allergy and in general food allergies are at higher risk. I mean, they're more susceptible due to the sort of Th2 skewing of their immune system, the immaturity of the immune system. They tend to get a lot of infections, and they're also received many courses of antibiotics for ear infections, and they are definitely a very vulnerable population. So in the subsequent studies, which has been presented as a late-breaking oral abstract during this EAACI Congress, international group of researchers conducted a clinical trial that found that extensively hydrolyzed formula with human milk oligosaccharides reduced rate of upper respiratory tract infections in infants with cow's milk allergy. So let's discuss those results in more detail. This is a cinnamon study, or this is a cinnamon study. It's a controlled double-blind randomized multi-center study involving centers in Europe, UK, and Singapore. The study compared two formula-fed groups designed to show non-inferiority in growth, which was the primary endpoint, as well as infection rates, related drug use, and as well as fecal microbiome in infants with cow's milk protein allergy. The study included older infants compared to the healthy infants. Those were between ages 0 to 6 months with the diagnosis of cow's milk protein allergy, who are not being breastfed at the time of the enrollment. And physician diagnosed cow's milk protein was defined as per standard clinical practice. So at least 2 symptoms were present, including either persistent crying, regurgitation, liquid stools, constipation, atopic dermatitis, urticaria, or other immediate symptoms. However, if diagnosis was based on the positive specific IgE or positive skin prick test, only 1 symptom was required from the above listing. The design was this is a randomized blinded trial. The enrolled participants were randomized 1-to-1 to either receive test formula with human milk oligosaccharides or control formula for 4 months. And at 4 months in the study, the primary endpoint was evaluated. It was a weight gain per day. Those infants were also followed for additional time until the V6 time point, which was 12 months in the study. And at that time, the secondary endpoints have been evaluated, such as growth parameters, the rates of adverse events, medication use, infection rates, etc. The study formulas were identical with the formulas that were used in the hypoallergenicity study. So we were comparing formulas that were identical except for the slightly lower content of protein and added 2 human milk oligosaccharides in the test formula. The study met its primary endpoint. So there was 194 subjects enrolled who were randomized 1-to-1 into the treatment groups. 51% of participants were male with a mean age of 3.2 months with the standard deviation of 1.7 months. The range was quite wide, between 0.1 months and to 6.1 months. As a reminder, infants were fed the study formula for 4 months, and after 4 months in the study, the primary endpoint as a weight gain per day was evaluated, and as per the definition of and the non-inferiority design, this study showed that there is comparable weight gain in infants who were fed with the formula. I just want to point out that that the test formula had a slightly lower protein content, so it might be potentially responsible for the slightly lower weight gain in that group. I want to now focus on those secondary endpoints, specifically the infection. So just to show you more graphically that the difference in mean body weight over the months in the study. And you could see that the red lines represent formula with human milk oligosaccharides, and blue lines represent the control formula. So there is a slight difference between those two formulas, but they were not. They were within the interval that was allowed by the design, the non-inferiority design. But even more interestingly, the study replicated many of the observations from the healthy infant study, and it noted relative risk reduction of infections between V0 to V6. This graph shows, compares or represents the infants with at least one infective episode. This is in the context of direct comparison between those who were fed with formula with HMO versus controls. The dark blue bars represent analysis in the full set of participants. The pale blue bars represent analysis per protocol. And you can see that for lower respiratory tract infections, upper respiratory tract infections, otitis media, as well as the gastrointestinal infections and acute diarrhea, there was a reduction in the reported infections while in the study. So this is representation of relative risk in this comparing HMO versus control formula. And another way of looking at the data for the infections while in the study, it's a forest diagram, and you can appreciate that there is a significant decrease in odds ratio for otitis media in the study. And while there were calculated odds ratio were generally in favor of the formula containing human milk oligosaccharides, the confidence intervals were such that those differences were not statistically significant, which may be in part explained by the fact that those were not the primary endpoints, and the study has not been powered for detecting those outcomes. However, when the incidence rate was estimated specifically for respiratory tract infections per month of study formula exposure, and this analysis was done on the full set, looking at the entire duration of the study between V0 to V6. There was a reduction in the estimated incidence of respiratory tract infections in the lower respiratory tract, but it wasn't statistically significant. However, there was a statistically significant reduction in the upper respiratory tract infection of 42% with a significant p-value of 0.003. So these are truly very interesting results. So my key messages from this presentation are that human milk oligosaccharides provide the substrate for the developing gut microbiome of young infants. The study suggests that human milk oligosaccharide composition of human breast milk does influence development of cow's milk protein allergy. Our clinical trial that evaluated hypoallergenicity of extensively hydrolyzed whey-based formula containing 2 human milk oligosaccharides was the first study in infants with, and young children with cow's milk protein allergy. The important finding from that study was that we confirmed that the new formula containing human milk oligosaccharides was well tolerated by more than 90% of infants and children with IgE-mediated cow's milk protein allergy that tends to be more severe in phenotype, thus meeting the generally widely accepted criteria for hypoallergenicity as stated by the American Academy of Pediatrics. The second very important message from the studies exploring the whey-based extensively hydrolyzed formula with human milk oligosaccharides comes from the cinnamon study. And that study showed that long-term ingestion, the feeding of the formula for 4 months is associated with normal growth in infants with cow's milk protein allergy. Furthermore, as a secondary outcome, cinnamon study showed that this whey-based extensively hydrolyzed formula with human milk oligosaccharides was associated with a significant reduction in the frequency of upper respiratory tract infections, as measured by episodes per month of study formula exposure for the human milk oligosaccharide group, as well as otitis media with significant reduction and difference between the HMO and control formula. So interestingly, these reductions in frequency of infections that were observed in the current study were really consistent with the data reported from the healthy non-allergic infants who were fed with this with the formula supplemented with human milk oligosaccharides since birth. This truly supports the concept and advances the concepts of modifying infant formulas to enrich it into the immunomodulatory components that are present in human milk. Thank you very much for your attention.
I would like to thank you all to have listened so carefully to this very interesting webinar.